just bring them back to 100%. Fantastic. So with that, I wanted to introduce our first speaker. Our first speaker is Dr. Larry Hill. Dr. Hill is a founding member of the American Association for Community Dental Programs. He has served as a dental director for Cincinnati Health Department for 30 years, during which Cincinnati fluoridated its water supply, directed a dental clinical network, and developed one of the first school-based dental student programs, which was the baseline for the Still America that you see out there right now. And with that, Dr. Larry Hill is the Executive Director for AACDP, and welcome, Dr. Hill.
Thank you. I want to welcome everyone to this session and to this series of sessions. We are really thrilled to be able to continue to provide you with the program that had been planned, and it's appropriate that this is the beginning of Public Health Week. So we're kicking off Public Health Week, and I think we are all observing in real time the need for a prominent public health presence in all of our communities and throughout the country. I'm particularly pleased to be able to, that the American Association for Community Dental Programs is partnering this year with the California Department of Public Health and the Office of Oral Health, as well as the California Dental Association in bringing you these sessions. And with that, can we go to the first slide? Maybe we can go to the second slide, I guess. So I want to mention and acknowledge the sponsors for this program. We are really gratified to have all the cooperation and partners that we've had in the meeting this year. You can see them up here: the California Department of Oral Health, California Dental Association, DentaQuest, and the American Dental Association and ADEC, which have their contributions have been very important to us in bringing you these sessions. So the next slide. These are the folks that have put this program together, and I have to say this has been just a wonderful group of folks to work with. Normally, I'd be having them all stand, but so we'll just assume that they're all standing. Except for Myron, and I'll get back to him in a minute, but Bahar, who you just heard from, Jared Fine, and Jay Kumar from California, myself, Katrina Holt and Sarah Colo from the National Maternal and Child Oral Health Resource Center at Georgetown, who provide us with great assistance and support, and Roland Tellier. Who is the person who was processing all of your registrations. I want to go back for a second to Bahar and say that, just to say that she is incredible. She has been the coordinator for the process and has been absolutely great and keeping us all on track. And Jay and Jared have done a wonderful job of coordinating the California presence in this meeting. But I want to mention for 1 second, I want to mention Myron. Some of you know Myron. A number of you should know Myron Alukian, and many of you don't, but Myron was the dental director for over 3 decades for the city of Boston. Spent 50 years in dental public health, got his and was only the second dentist to be president of the American Public Health Association. And but Myron is not on the call, is not on this call today. Myron is at Beth Israel Hospital on a ventilator. I know he is extremely disappointed at not being able to be with us. He's been in the hospital for about a week. As of yesterday, he was holding his own. And I just hope that you'll all keep Myron in your prayers. The next slide, please. So just a quick minute about the American Association for Community Dental Programs. We were established in 1983. And the reason that for this association being established is that before that time, in public health, the feds talked to the state dental directors, and the state dental directors communicated with the feds. There was very little communication, and I'd have to say probably very little respect for the folks working at the community level in county and city health departments, in nonprofits, and so on. And in the meantime, these were the folks, these are the very folks that carry out the work, that are the closest to the communities that they're working with. They're working in the communities. And so they see the problems every day that folks have in gaining access to care. And they're developing programs that address some of those very needs. But back before 1983, not very many people were talking to us. And so we saw a need to create an organization that would provide basically provide a platform and a voice for people working at the community level. And it's very important. And as a result of that, there's been a community voice in the development of some of the objectives for Healthy People 2000, Healthy People 2010, Healthy People 2020, and other national efforts. I mention that because most of you that are here today are people working in community programs, and there are opportunities. We need you to be active in this organization. And so, at different points throughout the presentations over the coming weeks, we'll discuss how you might be involved. Some of the things that we've done is developed a model framework for community oral health programs based on the 10 essential public health services. We've developed a guide for developing and enhancing community oral health programs. So some of you are not dental folks, but you've been charged with developing a dental program. That guide, and we hope to update that soon, but that guide was developed several years back, but everything in it is very much appropriate today. Where do you start? How do you go about this? The Bellwether is developed by the folks at the Maternal and Child Oral Health Resource Center. It's a newsletter on what's going on in oral health, significant issues at the community level, and the website's listed there at the bottom. The next slide. I've already talked too long. The next slide, please. So again, we want to thank all of our sponsors who I mentioned before. Is there another slide there? No. So okay. I saw that I'm going to have to defer to Bahar. I saw Dr. Nagy next, and
yes.
Okay, then you go ahead.
Thank you so much. Thank you so much, Dr. Hill. As we are going through this next 2 hours, I'm going to review our agenda after the warm welcome that Dr. Hill provided us. So as you have received in the many emails that we sent you, the title of our webinar today is Update on Community Dentistry in the Time of COVID-19 and Sustainability of Community Dental Programs. We just saw that it is timely to give some update on COVID-19. Many of you are in the front line working with community, working with community organizations around that. So we're going to have that. And at the same time, we just want to give an update and kind of continue on some of the areas that we have worked on around sustainability of community dental programs. So here's our agenda for today. I just wanted to make sure that you have that in front. So with that, I'm going to go to our next speaker, Dr. Richard Nagy. Dr. Nagy is currently the president of the California Dental Association and also a fellow of the American College of Dentistry and International College of Dentists. He's the former director of postgraduate periodontics and department chairman at the Greater Los Angeles VA healthcare system, as well as faculty at UCLA, and course director at the local dental hygiene programs. He's the past president of Santa Barbara Venture Dental Society, as well as the California Society of Periodontics and Western Society of Periodontology. Dr. Nagy, we would like to hear your update from CDA in these COVID-19 times.
Hello, and good morning to everybody. And it's a pleasure for me to be here with you today, even though being in San Diego together would probably be more pleasurable for all of us, I am sure. I do have to say how impressed I am with the leadership of the American Association for Community Dental Programs to carry on with this conference in light of the COVID-19 pandemic. The world has changed tremendously, and the last few weeks have been an unprecedented time in our nation and has significantly impacted the provision of dental care in California, as well as the rest of our country. CDA has been working diligently to support the dental professionals in many ways since the pandemic started. These included coming out early with an advisory for dentists just to see dental emergency cases only. And this was before our governor placed a shelter-at-home order for California. And during these times, we have advocated for our members to contribute to their community's needs, encouraging dentists to continue seeing those with emergency dental care to keep those people out of the ERs, which really don't have room for them, and also to preserve PPE whenever possible for frontline healthcare workers. We have set up PPE donation programs to move this essential protective equipment where it is most needed to the frontline healthcare workers. And we are doing this regionally through our local dental societies. Additionally, many of you may be aware that last Monday, Governor Gavin Newsom issued broad emergency orders to expand the healthcare workforce, including dentists. CDA was successful in getting legislation passed in 2008 to allow this in anticipation of an emergency need sometime in the future, and here we are now. And we are excited Monday to hear the governor bless it and expand it. We are actively pushing out this message to California dentists and dental professionals to let them know, because they are anxious to contribute during this pandemic crisis. Lastly, I would like to let all of the dentists present today to know that we have been working feverishly to ensure dental practice owners and staff are included in economic relief packages, so the resources will be available when it's safely time to return to work for patients, staff, and for our local communities. My comments this morning are not meant to be a long list of CDA activities. But in this unique time of need, I felt compelled to share some of what me and my colleagues day and nights look like, and hope you know CDA has your back. At CDA, we know that effective public health programs that you are committed to providing in your communities are a vital partnership with the dentists that provide care in their offices and clinics. I am pleased that today we can feel quote unquote normal as we learn from each other over the next 2 hours and upcoming days. And those circumstances have kept you from actually being in California right now, I would like to welcome you as if you are. So thank you and have a great meeting.
Fantastic. Thank you so much, Dr. Nagy. We really appreciate that. For participants, we know that, I announced that we're going to have a Q&A at the end, but since Dr. Nagy wouldn't be able to stay with us till the end for the Q&A, we're going to open it up for a couple of questions while we have him with us. So if there's any questions that you have for Dr. Nagy around CDA and how, as a professional organizations, they're responding to COVID-19 and all of that, please go ahead and put them on the Q&A section, and we're gonna bring them on. I know I just announced it, so I'm gonna give it a second to see if there's any questions. Dr. Nagy, I can imagine you are very busy these days. and we really appreciate you as a, yes. Tell us a little bit, how was it to kind of like get us started with all of that right away?
Well, at CDA, we always are looking for what's coming in the forefront that affects dentistry in the state and affects our members. And then getting wind of the pandemic that started in Wuhan, China, we already started discussions on what we were going to do if and when this pandemic hit California and the United States. So we were prepared. We were ready once we saw what was happening, the increase in people exposed and the increase in deaths. We knew it was time to start protecting our dentists, our dental team, and the patients in our communities. And that's when we met and then created the advisory for dentists to only see emergency dental patients for treatment that, if untreated, could be life-threatening for the patients. So again, we're always in discussion. I have a meeting today at 12:15 with our task force on COVID-19. That's why I have to leave early, because we are always looking in the future of how to be prepared. Preparedness is the key. Thank you.
Mm-hmm. Great. Yes, thank you. We have a question, actually a comment. Thank you, Rick and CDA, for your exemplary leadership in keeping our dentists and communities safe.
You're welcome. We'll take that. Thank you.
That's great. That's great. That's great. That's great. Yes. Let me see if there is any other questions. No other questions. So with that, we want to thank you so much for your time. And I know there were some resources that CDA put together right away. I think even sooner than ADA, it was out there, the CDA recommendation.
Correct.
So if there was any links that you thought that we could share with our attendees, please send them to us, and we're gonna, And I know things keep changing, right?
Correct. But just keep going to cda.org/COVID-19. We are always updating when new information comes immediately. Again, anyone can access it, cda.org/COVID-19. And I look forward to the rest of your the presentations today and over the coming days. This is a great topic of interest to me personally, and I think public health, especially what's going on right now, is at the forefront of need. So thank you so much.
Thank you so much, Dr. Nagy. Fantastic. So with that, we are gonna move to our next speaker, Dr. Tim Ricks. But before that, I would like Dr. Larry Hill to give us an introduction of Tim. Please go ahead, Dr. Hill.
Thanks, Bahar. You know, I just want to mention real quickly a couple of things. One of them is that the California Dental Association and the folks in dental public health in California have a very special and unique relationship, and I want to congratulate you all on that, and you know the work that you do together to further the oral health of folks living in California. I also wanted to mention that normally speaking, we would tell you that you can where the bathrooms are located. I have no idea where your bathrooms are located, so wherever you can find one, good luck. We'll move on. It's really a pleasure for me to have the opportunity to introduce Rear Admiral Timothy Ricks, who currently serves as the Chief Dental Officer of the United States Public Health Service, as well as the Assistant Surgeon General. As such, he serves as the Surgeon General's spokesperson on oral health and interacts with chief dental officers from other countries, with military chief dental officers, with leaders in organized dentistry, and with state oral health programs, and many more. He currently oversees the development of the second ever Surgeon General's report on oral health, and you're going to hear a little bit more about that. Just a couple of things to mention. Rear Admiral Ricks has served in the U.S. Public Health Service for over 20 years. I found it interesting that at one point he served as a military police officer in the Army National Guard. A little bit unusual for some of our dental officers. He's a recipient of numerous United States Public Health Service and Indian Health Service National Awards. He's board certified. He's a board certified diplomate of the American Board of Dental Public Health and a fellow of the International College of Dentists. So with that, as you might imagine, there's an incredible amount of things going on in public health out of the Surgeon General's office right now and at the federal level. So it's my pleasure to turn this over to Dr. Timothy Ricks. Thank you.
Thank you very much, Dr. Hill, and thanks again to AACDP for inviting me for a second year to speak to you, albeit online this time. Before I get started, I just want to say I value and really appreciate the work that you do each and every day to serve America's most vulnerable and underserved populations. So my hats are off to you, especially in this public health crisis, for all that you're doing. So as Dr. Hill mentioned, my original presentation, I was going to talk to you about the Surgeon General's report on oral health, but I'll also talk about the federal guidance and federal response with relation to COVID-19. Next slide. So before I get started, let me talk a little bit about the U.S. Public Health Service. The U.S. Public Health Service, for those that don't know, is one of 8 uniformed services in the United States. And our mission is to protect, promote, and advance the health and safety of the nation. We have U.S. Public Health Service dentists serving in 4 different departments. Within the Department of Justice, our dental officers provide care to inmates in Federal Bureau of Prisons. Within the Department of Homeland Security, our dental officers serve both in the Immigration and Customs Enforcement Health Service Corps and in the U.S. Coast Guard. And then within the Department of Health and Human Services, we have dental officers that provide care to Native Americans in the Indian Health Service, and dental officers that serve in the Food and Drug Administration, Health Resources and Services Administration, Centers for Disease Control and Prevention, and the National Institutes of Health. Next slide. So as Dr. Hill mentioned, the first thing I want to talk about is the second ever Surgeon General's report on oral health. Next slide. So since 1964, beginning with the groundbreaking report on smoking and health, the Surgeon General of the United States has commissioned 62 Surgeon General reports, with reports on smoking accounting for most of those reports, including the most recent one that was released just a couple months ago on smoking cessation. The first report on oral health was commissioned by then U.S. Surgeon General Vice Admiral David Satcher in 2000. Entitled Oral Health in America, the report had as its major message that oral health means much more than just healthy teeth, and that it is integral to the overall health and well-being of all Americans. So while research before this report really had shown the growing associations between oral health and systemic health, this report is often credited with taking that conversation to the next level, leading to many of the collaborations across the country that address the health inequities, oral health inequities that we still see today. Next slide. So as a follow-up to that groundbreaking report in 2000, 3 years later, the Surgeon General released a national call to action to promote oral health. And this expanded on 5 critical key action areas that were outlined in the report. The goals of this call to action were to promote oral health and quality of life, and to eliminate oral health disparities in the U.S., many of these disparities of which still exist today. Next slide, please. So with such a well laid out plan, you would think that after spending billions of dollars on research and practice in promoting oral health in this country and across the globe, we would have solved this by now. But as recently as 2016, the burden of oral disease still persists. 4 of the top 30 global disease burdens as reported by The Lancet, which is a UK publication, are related to oral health, including untreated dental caries in permanent teeth, severe periodontitis, untreated dental caries in primary teeth, and severe or complete tooth loss. And in fact, untreated dental caries in permanent teeth is the #1 global disease burden back in 2016. Next slide. So do you remember that when we began this millennium, that the biggest threat we had was Y2K and how that was going to change everything? Well, Y2K ended up being a bust, but the digital age certainly took off. So over the last 20 years, we've seen a huge change in the digital age. E-commerce is a $3.45 trillion industry now. Mental illness, which once was hidden in the shadows of stigmatization, is now at the forefront in many of our society issues, as it is interrelated with substance abuse. The health disparities that we saw 20 years ago, oral health disparities and inequities, continue to persist today. Healthcare expenditures continue to increase and have more than doubled over the last 20 years. So there are a lot of things that continue to impact oral health and shape the way we practice as oral health professionals. And now, as we've seen, there are emerging public health threats. So even before COVID-19, we saw things like human papillomavirus being the leading leading to oral cancer. We saw the increase in e-cigarette use, especially among teens. We've seen a lack of military readiness due to oral health. We've seen the opioid epidemic, and now we're seeing COVID-19 and its impact on oral health as well. Next slide. So our Surgeon General has a motto that we can achieve better health through better partnerships. And so the federal government has really made a strong effort to engage with private partners such as AACDP across the country. And the Surgeon General, whom all of you have probably seen numerous times on press briefings, has made oral health one of his central themes as the Surgeon General. So he's listed several major priorities as Surgeon Generals before him have done, and his include substance misuse, which envelops both the opioid epidemic with tobacco and e-cigarettes, community health and economic prosperity, which is trying to show the economic impact of good health and poor health. And then in terms of health and national security, the Surgeon General has looked at how health impacts both military eligibility and readiness to deploy. And what we know is that oral health is really intertwined among all of these priorities. So we know that oral health, especially periodontitis, is interrelated with tobacco use and smoking. We know that oral health affects the economy through missed school days, missed work days, and economic conditions drive private insurance coverage as well as access to dental services. We know that oral health affects both recruitment in the military and force strength as well. So the Surgeon General's recognize these interrelationships between oral health and his other priorities, and he often refers to oral health as value added, not an add-on. Next slide. So back in 2018, the Surgeon General commissioned the second ever Surgeon General's report. And so as we have planned this 2020 report, which we hope it will come out later this year, we're looking at what has changed since that first report in 2000 and what's new. What's new, things that were not even on the horizon back in 2000. But more importantly, as we consider those changes, we're looking at the futures as well and how these changes will create new strategies and solutions to meet the challenges that we all face in oral health in the future. But we have a clear starting point with the Surgeon General's charge. This report that will be forthcoming will be based in science. We have been thoroughly examining current knowledge, including evidence of successful practices, as well as research. There are 6 major sections of the report, which I'll detail later, and these 6 sections will look at current knowledge, practice, and perspectives related to oral health in that particular section. And these will be all vetted through an internal and external review process, which I'll detail a little bit later as well. Next slide. So again, the big questions to answer is, where are we now? What advances have we made since that 2000 report? What were some of the challenges that we had in 2000 that still exist today? What are some of the new threats that are emerging? And what are some of the promising new directions for research and improvement in oral health? Next slide. And so here are the 6 different sections of the report. One section will look at the effect of oral health on the community, overall well-being, and the economy. And again, that's addressing that community health and economic prosperity priority of the Surgeon General. And then we'll have 2 sections that are looking at oral health across the lifespan. One will be looking at children and adolescents. The other will look at adults and older adults. Then we'll have a 4th section that is looking at oral health integration into primary care and vice versa. Workforce, including the different alternative workforce models that are in use today and perhaps in the future, and dental practice as well, the changing landscape of dental practice. A 5th section will look at the effects of addiction and mental health disorders on oral health. And finally, we'll have a section that will look at emerging technologies like artificial intelligence and promising science that will transform oral health in the future. Next slide. So approximately 400 researchers and health professionals have contributed to the report thus far, and we're very grateful for their volunteer time and effort. These include individuals working in public and private care settings, in federal and state agencies, in dental organizations as well, and in research as well as clinical and administrative roles. The concept of the report, as I mentioned, began in early 2018 when a special committee was created to begin the framework of this report. In November of that year, the Surgeon General held a listening session that was sponsored by the Centers for Disease Control and Prevention Division of Oral Health, and we had over 150 key stakeholders from around the country that met at this meeting in Washington, D.C. Just after that, contributions were solicited by the agency that is serving as the primary author of the report, which is the National Institute of Dental and Craniofacial Research, which is one of 27 institutes within the National Institutes of Health. The writing and editing have been happening at a furious pace, which really is twice the speed of the 2000 report that took 4 years to finish. And the different chapters of the report are currently undergoing a scientific and technical review by a team of experts. And after that review is over, the report will go through a federal clearance process, which is very detailed. It will go to each of the HHS agencies, to the Surgeon General, to the Office of the Assistant Secretary for Health, and ultimately the Office of the Secretary of HHS, who is currently Alex Azar. Next slide. So I want to provide you a few of the resources that you could find out more information about the report as it stands now. As I mentioned, there was a webinar that NIDCR had back in January of 2019 that was during the government shutdown, if you remember that. And that, as well as the Surgeon General's listening session, some of the presentations for those are available online. The report itself, once it is finalized, will be like all the other Surgeon General reports at surgeongeneral.gov, or you can go to this link, hhs.gov/Surgeon General. Okay, so next slide, please. Let's change gears a little bit and let's talk a little bit about the topic of the day, and that's COVID-19. And specifically, I'll talk about the federal response. Next slide. So first, I think it's important for us to take a step back and look at what has happened. In early February, we had less than a dozen cases, and this was considered an epidemic on foreign soil. By early March, as we all know, things began to move very quickly across the US and around the world. On March 17th, dentistry became directly impacted. So in the March 17, 2020 White House Coronavirus Task Force press briefing, White House COVID-19 response coordinator, Dr. Deborah Birx, recommended that hospitals and dentists cancel all elective surgeries over the next 2 weeks in order to free up hospital beds and space. The task force has stated that its recommendations are not mandatory. Next slide. So this was followed up by 3 more mentions about postponement of elective services, dental services. On March 18th, in a somewhat confusing message, CMS, the Centers for Medicare and Medicaid Services, recommended that all non-essential dental exams and procedures be postponed until further notice. And it wasn't very clear what non-essential dental exams and procedures were. But two days later, the Centers for Disease Control and Prevention updated their guidance, recommending that dental facilities postpone elective procedures, surgeries, and non-urgent dental visits, and prioritize urgent and emergency visits and procedures now and for the coming several weeks. And then finally, 2 days after that, the Surgeon General, Vice Admiral Adams, asked health systems to cancel or delay non-essential elective procedures in a way that minimizes potential harm to patients. And he made a point of saying these include dental procedures as well. Next slide. So the Centers for Disease Control and Prevention Division of Oral Health has issued 3 rounds of interim guidance for oral health professionals, with the last guidance coming out on March 27th, just a couple of weeks ago. And there are CDC Division of Oral Health is already working on new guidance that is currently under review. But some of the key concepts of that March 27th guidance are as follows: that dental settings have unique characteristics that warrant additional infection control considerations. Number 2, that dental procedures should be postponed, surgeries, non-urgent dental visits, and contact patients prior to doing any emergency procedures. Stay at home if sick, and no steps to take if a patient with COVID-19 symptoms enters your dental facility. The third key concept was, again, stay at home if you're sick. 4th was contact patients prior to providing any kind of urgent or emergency dental treatment and screen them. And then 5th, again, know the actions to take if a patient has suspected or confirmed COVID-19. Next slide. So with regard to the Centers for Medicare and Medicaid Services, CMS has provided states with guidance and templates on covering telehealth services, including teledentistry. And updates on that guidance can be found in the link that is shown. CMS is working closely with Medicare, Medicaid, CHIP, State Dental Association to learn more about how states are allowing teledentistry services and which services they're providing, which codes they're being are reimbursing for. As you may be aware, the ADA has 2 codes for teledentistry, D9995 and D996. But it's really all the CMS rules or reimbursement schedules are enacted at the state level. Next slide. The Food and Drug Administration, too, has been providing daily updates on their coronavirus response, and the link to their updates is shown at the very top of this slide. As you've heard about during the White House press conferences and in the news media, the FDA has instituted a coronavirus treatment acceleration program that will bring new, safe, and effective therapies to patients. And they're looking at other issues such as decontamination of N95 respirators. So I've included a few links there that would be really helpful for you to look at to see what the FDA is doing behind the scenes. Next slide, please. Now, with regard to the clinical agencies in the Department of Health and Human Services, or the U.S. Public Health Service. The U.S. Public Health Service really has 5 clinical agencies: the Indian Health Service, the ICE Health Service Corps, the Federal Bureau of Prisons, U.S. Coast Guard, and the Health Resources and Services Administration. So here's an update for 3 of those in relation to COVID-19. The Federal Bureau of Prisons, as you may have read about or heard about, has limited prisoners to cells for a 14-day period, and I believe that began last week, and that link provides you more information. The Indian Health Service has developed teledentistry guidelines, a document on how providers can talk to patients about their COVID-19 questions, and especially in regard to how safe a dental facility is. And the Indian Health Service has created some other documents. And if you're interested in any of those, you can email me and I can share that with IHS leadership and they can share it with you. And then finally, I know many of you are grantees or work with the Health Resources and Services Administration. They developed a list of frequently asked questions for community health centers, and these can be found at the link that is provided there. Next slide. The final thing I want to describe to you is how we're communicating through on dental issues with regard to COVID-19. This is really being done on 4 different levels at this time. So first, I've created, as Chief Dental Officer, I created this public-private partner dental coordination group, and I've brought in a bunch of federal people from representing CDC, CMS, FDA, and some other agencies, and then some of the dental organizations, not all of them because that would be a very large group, but some of the largest dental organizations I've brought in, and that we're sharing information. A second thing that I'm doing, I'm working with AACDP on this, is just direct communication to different organizations and back and forth as well, and then sharing that information as needed. I'm also trying to communicate with our other federal dental services, including U.S. Air Force, Navy, Army, and the VA. And then we're also leveraging our U.S. Public Health Service Oral Health Coordinating Committee, which has representatives from across the Department of Health and Human Services, and our Dental Professional Advisory Committee, which is a dental component that directly advises the Surgeon General. So there's a lot of communication things happening. I think we're all in information overload right now with regard to COVID-19, but just know that the federal government on the dental side, we're trying to communicate as most efficiently as we can without adding noise to the ongoing conversations. So this concludes my brief summary of the federal response and federal guidance to date. Again, I want to thank AACDP, Dr. Lukey and Dr. Hill, Bahar, Katie, and the entire planning committee for the invitation. And I hope all of you continue to stay safe as we all work together to get through this. Thank you very much.
Thank you so much, Dr. Timbrix. We really enjoyed the presentation. And I know I already considered some questions, but if attendees, we can please wait until the end so that we can bring out those questions. But please feel free to put them in the Q&A section. Please say whom your questions is intended to go to. So with that, I'm going to introduce our next speaker, Dr. J. Kumar. If we can proceed to the next slide, KD. Thank you so much. Dr. Kumar is our state dental director, and we're happy that we have Dr. Kumar here in California. He was appointed to this position as the state dental director in California Department of Public Health in August of 2015. Dr. Kumar is a board certified specialist in dental public health and a former director and president of the American Board of Dental Public Health. Before joining the California Department of Public Health, Dr. Kumar was a state dental director in New York, where he held multiple positions. So Dr. Kumar, welcome, and we look forward to hear the update from California as well as your take on the sustainability of local oral health programs.
Thank you, Bahar. Thank you, Dr. Tim Ricks, for that excellent presentation. We are looking forward to the Surgeon General's report. Thanks for all the work you're doing at the federal level. Thanks for all the resources regarding COVID. I would like to take this opportunity to thank the AACDP Planning Committee for making this happen. We have met almost every week for over 6 months to bring you this webinar series. Last year, Dr. Alukian approached me about sponsoring this meeting in San Diego. And I've known Dr. Malukian for a long time. We have served on many committees together, and he wanted this meeting to be the biggest meeting. And unfortunately, he's not here with us today to participate. I wish him all the best for a speedy recovery, and I'm looking forward to seeing him at the next webinar. So when we met as a planning committee to plan the agenda for this meeting in San Diego, we thought of creating an ambitious agenda to learn, understand, and share what governmental local oral health programs are doing and how they are partnering with clinicians, other sectors, including foundations, and to find how they are trying to improve oral health. We didn't want all that effort to be wasted because of the disruption caused by this pandemic. So we hope this virtual platform that we are bringing will give you the same content. And I want to mention one thing that when we structured the local oral health program here in California, we used the AACDP resources. So many of you are very familiar with the resources and what this organization has been working on over the years. I want to take some time and provide you the context of my talk. In November last year, local oral health programs in California met for their annual meeting. So one of the issues that was raised at that meeting was about the sustainability of these oral health programs. A survey conducted by the Association of State and Territorial Dental Directors showed that there are more than about 100 city county programs in the United States. Obviously, we need more. I'm sure many programs across the nation, they're asking the same question about sustainability. A Healthy People 2020 objective is to increase the jurisdictions with a population size greater than 250,000 to have a dental program. So I'm going to give you a little bit of background. In the 70s, most large city and county health departments had a dental public health program. And these programs provided clinical services as a safety net for the residents because dental insurance benefit coverage was minimal in those days, especially for children. Over the years, the support for local health department has declined. The Trust for America reported that since 2008 recession, local health departments have lost about 55,000 positions. So if you look at inflated adjusted terms, the funding reduction has been substantial. The Affordable Care Act in 2010 focused on providing universal health insurance coverage, and they expanded community health centers and required not-for-profit hospitals to conduct community needs assessment and develop community health improvement plans. So this change has affected the local oral health programs in many ways, and local public health programs in many ways. We spend about $3.5 trillion in the US on healthcare, and only about a fraction of this on public health infrastructure and capacity. So this amounts to about less than $300 per person per year, whereas on healthcare, we spend over $10,000 per person per year. So the bottom line is that there isn't just enough money to support local public health services. So many local health departments have shifted the focus away from providing direct clinical services such as dental services, well baby clinics, and immunization clinics, etc. And now they are focusing on essential public health services such as assessment, policy development, and assurance functions. And they are more so focusing on social determinants of health. So in California, the main source of funding for local oral health programs is the 2016 tobacco tax, thanks to the California Dental Association for successfully advocating for these funds. We know that this revenue decreases over time, and we should start planning for sustainability of these programs. So what I'm going to talk today is as relevant for the nation as a whole. Okay, the next slide. So I'm sure you're fully aware of the number of new cases in the US and the world and the case fatality rates. This virus puts dental health personnel at very high risk. As you will see, there's a report that a dental worker already contracted this virus at work, and I wouldn't be surprised if we start seeing more reports on such events. The SARS coronavirus too, there is some good news about this today. I heard that the epidemic, especially in those cities like New York, may be plateauing, and California has done a remarkable job in containing the spread of this one through mitigation efforts, and I think California was the first state to implement some of these public health measures to contain the epidemic. So the SARS coronavirus too is unique in that it can be spread by droplets and aerosols. When I started my public health career, the AIDS epidemic had just started. It had a huge impact on the practice of dentistry. One of my tasks was to develop infection control practice guidelines in New York State. HIV, HBV, HCV are bloodborne pathogens, and this revolutionized infection control practice in dentistry. Gloves, masks, eye protection, and heat sterilization all became standard in dental settings. So now we use standard precautions for all patients to prevent transmission of bloodborne pathogens. To take care of COVID patients, we need transmission-based precautions. So dental offices are not equipped to implement these precautions. Because of the aerosols the dental procedures generate, and dentists, hygienists, and assistants work closely with patients, they are at very high risk for exposure. And compounding this is that there are asymptomatic patients who shed this virus. The needed personal protective equipment is not available, and they are prohibitively expensive. That's why CDC, ADA, CDA, ADHA, CMS, and CDPH have recommendations to postpone all routine dental procedures, surgeries, and non-urgent treatment. So here in California, we are working on putting together guidelines for managing emergency treatment in dental settings for those who are those who don't have symptoms of COVID or don't have COVID, and we hope to publish those guidelines soon. So now we have to start thinking about the post-crisis. And during this, so until such time that the shelter is in place, local health departments have a major role, especially the oral health programs should be disseminating these guidelines to all dental offices to make sure that they are complying with, they're in compliance. We don't want to send mixed messages about this, and we want to make sure every dental office knows about the current guidelines. The other issue is patients also should know about the temporary disruption in dental offices. So we have to inform and educate the public about this temporary disruption and help them to take steps to maintain good oral health, and they should be engaged in healthy mouth behavior. So as far as post-crisis world, where we can expect a low level of infection in the community, some people expect, some epidemiologists think that this will last for a long time, and also this may come back. So that in that situation, the practice of dentistry may have to adapt itself to this new environment, and we may have to look for COVID exposure status before undertaking extensive dental treatment in these patients. And this assumes that there will be widespread availability of rapid testing. So it is time to remind everyone what we do in public health. Public health is what we do together as a society to ensure the conditions in which everyone can be healthy. We are seeing public health being practiced now in all facets, identifying cases, isolating them, preventing the spread, gathering data, tracking the trends, educating and informing, developing policies, and supporting healthcare, as well as conducting research. Part of the reason for the lack of funding for public health is that public health and policymakers take it for granted of many of these public health services rendered. They don't see the impact of public health programs such as clean air, clean water, safe roads, community-wide interventions like water fluoridation, school-based interventions. Next slide. So this brings me to the topic of sustainability. I bring up this issue of funding and the local health department infrastructure now because of the current pandemic. If CDC, state, and local public health departments had the same kind of investment as the healthcare sector had, we would not be in this situation. It's a constant struggle for programs to find sustainable source of funding for public health departments at the local level. So I have to explain what I mean by sustainability. Sustainability is supporting the continuity of essential public health services. It's ensuring the continuation of program activities. It's helping to achieve oral health objectives. So nationally, there are 3 sources of funding for state oral health programs, and they are extremely limited. So CDC has funding for state program infrastructure. It's about $300,000 to $500,000 per state, and they're funding, I think, about 20 or 22 states. HRSA periodically awards funding for state workforce activities. California has one. Currently, they have not issued new notification for grant awards, and it's limited for state workforce activities. The other source of funding is the federal Title V block grant which supports state maternal and child health programs. As part of this, some 23 states or so use limited funds for dental programs. So there are no other dedicated source of funding for governmental local public health. Next slide. So this report, Public Health 3.0, made several recommendations. This was a report published by the Office of Secretary sometime in 2016, and it sharply defined the focus on addressing all factors that affect a person's overall health. The social determinants of health are the conditions in which people are born, live, and work and age. So I'm going to expand on this a little bit later on. So the Public Health 3.0 recognized the work of local health departments and also recognized the need for additional funding. Next slide, please. So there are several recommendations in this report. So these are actually for local health departments, and local oral health programs should review these recommendations. So I'm going to read some of the key elements from this report. So the first one is health departments will play the role of chief health strategist. And this is to drive initiatives in their community, especially upstream interventions to address social determinants of health. So some have said the more appropriate title for this is actually community health strategist. And that relates well with what you are doing at the local level. So the focus here on, again, social determinants of health, and you see it playing out now. There is a very nice piece in today's New York Times about how social distancing is a privilege enjoyed by only some, because many workers, they have to go to work, and when they go, they have to take public transportation, and all these expose the most vulnerable population to COVID. So the next one is public health department should engage partners in cross-sector collaboration between other health departments, intra-governmental departments, and community entities such as hospital, clinic, and other local businesses. And I'm going to skip the third bullet. This is as part of the oral health programs. They can provide examples of activities for accreditation purposes. That we have some of the very good population-based interventions, and we can implement quality improvement and performance measures in those programs, because as part of the accreditation, every health department has to submit some evidence of quality improvement and performance management systems, which are population-based, but not individual, personal, individual level interventions. Health departments, and the next bullet is about the collecting and compiling timely, reliable, granular level and actionable data to guide, focus, and assess the impact of prevention initiatives, and should take this data accessible to, and should make this data accessible to the community. So now let's talk about this in the context of oral health. Oral diseases are not reportable, and we don't have electronic health records, or at least electronic health records with diagnostic codes. We don't have timely data on dental caries, periodontal disease, tooth loss at the state level, let alone at the local level. We usually focus on dental visit and other behaviors, and at the population level, we rely on surveys, and these are getting harder and harder to accomplish because of the declining participation in these surveys. School surveys are conducted once in 5 years, and they are very labor intensive. So these data provide, again, only state level estimates. So in California, we are focusing on gathering the kindergarten assessment data on dental caries and untreated caries and reporting this to a central database. This has the potential to provide annual data as well as local data. So many states have school screening laws. This may be an opportunity to leverage that to get local level data. The next one is about funding for oral health. Local health department should be, the funding should be enhanced and substantially modified, and innovative funding models should be explored so as to expand financial support for this concept of public health 3.0. California has been in the forefront because of the tobacco tax funding for local oral health programs. Some counties like Alameda and San Francisco have tapped into sugar-sweetened beverages to support dental programs. I'm sure Dr. Jared Fine will expand on this later on. Next slide. This slide illustrates the evolution of public health over the last century. The period from the 19th century through much of the 20th century, public health became a function of governmental programs. Also, these governmental programs served as safety net for clinical services. Many city, county programs supported dental clinics as part of this initiative. For oral health, this was also the time of research to identify the role of fluoride in the prevention of tooth decay. Fluoridation started early. In 1945, it was also the time fluoride was introduced as topical agent in school programs and in toothpaste. This is how twice a year preventive dental visit became a norm. By 1980s, we started seeing declines in tooth decay. We observed that tooth decay shifted from a disease of the rich to a disease of the poor. The next phase started in 1988. The Institute of Medicine issued a report in 1988, The Future of Public Health, and it described the many challenges faced by the governmental agency in supporting clinical programs and the inability of these programs to address chronic diseases in the aging population. To quote from this report, "Nation has lost sight of its public health goals and has allowed the system of public health activities to fall into disarray." The report defined common set of core functions and 10 essential public health services, and this has guided all the programs, including oral health programs. So the Great Recession of 2018 and the enactment of ACA is shaping this new era of public health 3.0. The focus of this era is on social determinants of health. It's critical that we pay attention to this because oral health programs have to align their activities with broader public health programs and activities at the local level. Next slide. So this slide illustrates how social determinants of health impacts oral health. It is the zip code that matters more than the genetic code. On my left is a graph showing dental visit rates among adults over 18 years in Oakland by census tract. On my right is the percent of 65-year-olds with tooth loss, all teeth lost. This is the cumulative effect of tooth decay and periodontal diseases. You will see the variation by census tract. If I superimpose income, I'm sure I'll see a very similar variation. So census tract with lower income, having lower dental visit rates, have higher tooth loss. So how do we address these disparities? The CDC suggests several approaches to addressing social determinants of health. Consciousness raising is one. This is a process to engage the people to discuss their concerns and issues that can be used to inform programs and policy change as well as the healthcare sector. This process may provide insight into the utilization of dental services, the barriers they face, and how often or how well daily mouth care is practiced, and all the myths about oral health and healthcare. For example, the results of a focus group of Medicaid beneficiaries in California showed that many didn't know the dental benefits. Another common complaint we have heard is that many communities, in many communities, there is a lack of trust in the providers that they often seek dental care. Another one is community development. This involves the community in creating the required change. For example, establishing or expanding a dental clinic in the neighborhood, or bringing a provider to a community where there is shortage. So these may require other strategies. For example, there is if you have sufficient number of providers in the neighborhood, then they don't have to rely on transportation to travel, and this helps in them making and keeping multiple appointments. So these two approaches can be accomplished through community engagement process. The other one is health promotion. Typically involves efforts to outreach to individuals, families, and populations to influence their knowledge, attitudes, and skills around a particular behavior, whether it is a dental visit or risk factors like tobacco or sugar-sweetened beverages or healthy foods. Sometimes changing behavior requires other complementary strategies. For example, if dental offices want patients to report on time for dental appointments, there may be a need to address public transportation issues. So, the next one is about media advocacy. This is engaging the media to drive change. For example, media can bring a lot of attention to school dental screening requirements, or provide positive coverage about community water fluoridation, or discuss ways to address early childhood caries. And lastly, policy and environmental change. Local oral health programs can partner with other organizations to impact on policy changes. Sometimes a law requiring school dental screening may be the best way to increase dental visit rates. In other settings, system-level changes may be more appropriate, such as integration of oral health as part of prenatal care, or laws regarding toothbrushing in Head Start, early education and care settings, in nursing homes, in other settings. Next slide, please. This graph depicts the strategies and tactics under downstream, midstream, and upstream categories of what I call interventions. In the dental public health practice, we have focused on fluoridation policy as an upstream measure, upstream action, mandating communities to fluoridate, or requiring schools to promote dental assessments or screenings. But these efforts are not always recognized by the public. So what is usually recognized and much appreciated are the downstream clinical care provided. In this new era, we have to move from this stage to addressing individuals' social needs, not only dental, but also linking patients to communities' resources. As you will see, the role of community health workers is listed here as a tactic to address social determinants of health. Under the Medicaid Transformation Initiative in California, several dental pilot projects have tested this approach. So the challenge for local oral health programs is to maintain some of the clinical services they are currently rendering while addressing upstream determinants of health. Next slide. So the CDC developed a framework to conceptualize the integration of healthcare system and public health system to produce substantial and lasting health of individuals. This spans 3 buckets of prevention: traditional clinical interventions provided in clinical settings, in this case, dental settings; preventive interventions that extend care outside the traditional settings, such as school dental programs, virtual dental homes, and the third bucket, that is the population and community-wide interventions, such as fluoridation, toothbrushing, and water drinking fountains in schools, and similar community-wide interventions. Next slide. So our vision for California is to create a generation of cavity-free children. This is a priority right now, and we don't want to forget the other population groups. My concept of cavity-free includes not only caries-free, but also taking care of untreated cavities so that there are no children with open cavities. I realize that this is a lofty goal for all children, but is achievable for elementary school children. So therefore, we have an objective in the California Oral Health Plan to reduce tooth decay and untreated tooth decay in third grade children, which aligns with what most state dental programs are trying to accomplish and measure. So this requires a set of interconnected interventions that local health departments can work with their partners to implement. Starting with community water fluoridation, our objective is to increase the proportion of the population on fluoridation, but a priority is to maintain the currently fluoridated systems that reach about 61% of the population. So nationally, I think it reaches about 73% of the population who are on community water systems. Nationally, most of the systems that are not currently fluoridated are those that are really hard to fluoridate for various reasons, partly technical difficulties, partly cost, and most importantly, lack of community support. We are looking forward to the release of an innovative technology developed by a company, and it's based on a simple method using fluoride tablet technology. And that makes it easier to fluoridate multiple wells at a reasonable cost. So we are looking forward to some innovation in this area. The second component is supporting community clinical linkage programs. These are establishing connections between community and clinical sectors to improve population health. When clinical and community sectors work synergistically, then the system can improve care and support patients better than either of these sectors could do alone. We included this as a key strategy to ensure children who have tooth decay are at high risk for tooth decay and do not have resources, and they need to prevent and obtain treatment services. Enhanced collaboration among the public health, healthcare, and community non-healthcare sectors could produce better prevention and treatment outcomes. A good example of this would be school dental programs. The third component is a requirement in California that all kindergarten children are assessed before school entry. This brings together schools or education sector, public health sector, and clinical sector. California Dental Association established a system called the System for California Oral Health Reporting, and to gather all the data from schools. And we have updated the system and now in the process of improving it. So this can be a source of local sub-county data that Public Health 3.0 has advocated, and this is one of their main recommendations in the report. This is about the local level data. The fourth component is increasing dental visit rates, especially in the state Medicaid programs. Over the last 10 years, we have seen significant improvement in the utilization of dental services among children enrolled in the Medicaid program across the nation. The Medi-Cal dental program in California has made significant enhancement to the program to increase utilization, including supplemental payment, incentives, and a campaign to educate the beneficiaries. Local health departments work with program at the local level to increase utilization of dental services. School and preschool dental programs and kindergarten assessments are all designed to increase dental visit rates, especially preventive dental visits. Finally, an initiative to enhance oral health literacy by providing tools to dental offices to improve communication using health literacy principles such as plain language, visuals, and drawings and teach methods. So that is needed, and we are working on those tools. So we are creating a performance management system using result-based accountability scorecard to track progress. We just completed a survey of third grade children in California to assess the prevalence of tooth decay, untreated tooth decay, and sealant prevalence. We'll be repeating this survey maybe in 3 to 5 years. So we should know whether we have made improvements or not. The progress, however, will depend on how much of these interventions we are implementing and the reach of these interventions in the population and how well we are doing with respect to these interventions. So this should be reflected in the health of children as we move forward. Next slide. So here are some key takeaway messages for building a sustainable local oral health program at the city and county level. So these are my recommendations and some of my ideas. Number one is to institutionalize your program. This is an action of establishing rules and procedures in the organization. For example, Alameda County established the Oral Health Committee in 2012 as part of the County Public Health Commission, which provides oversight of the implementation, prioritization, and quality assurance of their strategic plan. The committee is comprised of selected public health commissioners, dental professionals, and oral health advocates who have the expertise and interest in advocating for policies that promote dental health. Second, you have to develop a mechanism to assess support for your programs and services, whether it is school-based programs, fluoridation, or any other program. And you have to get feedback from the recipients or the customers in order to understand the opportunities and challenges. Third, you have to define your successes and outcomes. And you have to have a system in place to measure your outcomes. Publishing a success story is a great way to communicate your efforts. Fourth, it is very important to inform and educate the public and policy makers about your program. You may want to create an annual event where you can invite decision makers in the community to share your successes as well as to inform them of the challenges. Fifth, develop the capacity to explore financial opportunities. Grant writing capacity is an essential skill, which is critically important to generate funding for public health programs. So you have to have an idea and a proposal in your file with clear objectives and asks that you can market at the right time. So if you don't have the capacity in your program, you should reach out to your partners in your community who can help. You may find a local foundation who may want to support your initiatives. So this is the right time to think about these ideas and have the proposal sketched out. Sixth, collaborate both with traditional and non-traditional partners. So I would like to highlight the need to partner with your hospitals here. So you know most of the traditional partners, but one partner that you may want to look at is hospitals here, because under ACA, not all not-for-profit hospitals are required to conduct community health assessment and health improvement plans. There is an opportunity to reach out to hospitals about preventable emergency room dental visits. It's a good topic to start with when you have discussions with hospitals about including oral health needs as part of their assessment and improvement plans. Another initiative that has the potential is promoting toothbrushing protocols to reduce non-ventilator related pneumonia in hospitals. There is some good evidence in California from Sutter Hospital, which implemented a quality improvement program to increase toothbrushing frequency, and they observed considerable improvement in pneumonia rates. Finally, standing up dental alone program is hard to sustain. Next bullet, please. Integration of program services into existing program, whether it is home visitor program, nutrition education, or any other program, is a sustainable way of addressing oral health problems. In summary, we are going through an unprecedented pandemic which have profound effect on dentistry. State and local health departments are leading this effort. I hope the public and policymakers will now recognize the need for robust governmental public health program at the local level and find the necessary resources to support them. So the future presentations in this webinar series are designed to bring new ideas, successful strategies and programs, as well as opportunities for collaboration and funding. Thank you.
Great, thank you so much, Dr. Kumar. We really appreciate that. And we're gonna move to our last speaker. I'm gonna make sure we have enough time for question and answers. So please put all of those questions in the Q&A section. The chat section is a little trickier for the panelists to respond back. Q&A is easier for us. So with no further ado, I want to introduce Dr. Jared Fine. Dr. Jared Fine is the former dental health administrator for Alameda County in California, where he served the public health department for nearly 40 years. He has organized in California and recognized in California and nationally as a visionary leader in public health policy, program development, and advocacy and community organizations. Here's Dr. Fine, my mentor and my colleague.
Thank you, Bahar. If
Sure.
we could go back to this title slide, that would be great. Yeah, first of all, I want to say good afternoon, and I hope you and your loved ones are well and staying safe. With all that's going on around the virus, I don't know about you, and I presume, like me, you've been looking for some positive to come out of it. And I heard something last night. That is, I was watching the news, and the mayors of Oakland, Berkeley, San Jose, and San Francisco were being interviewed. The moderator asked one of them, "What are you doing about the homeless in response to the epidemic?" And the respondent mayor from San Francisco said, "Our first concern is public health. Our first concern is public health." And then she said, "It's not as simple as some might suggest." Next slide. No, actually, back to the title slide. So in the next few minutes, I want to relate several stories to you that I think underscore the critical issues in building a critical mass for oral health advocacy and infrastructure at the local level. First of all, I'm going to ask some questions. How did Oakland get new funding to expand its WIC-based oral health program? How did 3 federally qualified health centers get funding for their dentists to screen and triage for diabetes? How did San Francisco get a $1 million dental sealant program for its old school district? And how did California Department of Oral Health go from one dental public health program on life support to the most vigorous and well-supported program in the nation? I want to share 2 short stories with you with which I will attempt to distill the keys for building critical mass oral health advocacy and infrastructure. When the American Fund for Dental Health, which was the foundation arm of the American Dental Association, partnered with the Robert Wood Johnson Foundation to fund the National Preventive Dentistry Demonstration Program, it underscored a shared vision articulated in the American Dental Association mission statement to promote the art and science of dentistry and the oral health of the American people. In the 1970s, this realization cemented my early belief that forwarding public health would happen by finding shared goals and natural partners in organized dentistry and in public health. Next. There you go. That partnership took the form over several years, with my serving as the dental director of the public health department, as well as on the board of the local dental society. Together, we partnered to implement a school-based dental sealant program, a geriatric education and service program, tobacco cessation training, an HIV and bloodborne pathogens continuing education course, and more. And serving on the Dental Society board also gained me the opportunity to participate in state-level advocacy and statewide efforts as well. Now here's a picture of the campaign poster from the Sugar Sweetened Beverage Tax Initiative campaign in Oakland on the window of the office of the Alameda County Dental Society, which leads to my first story. Next slide. In 2014 and 2015, when the epidemic of diabetes was surging, the city of Berkeley conducted a soda tax campaign that succeeded. San Francisco and Richmond did too in the next election cycle, but they failed to get enough support. When we developed the first strategic plan for oral health in Alameda County, we assured its viability by having it become a standing committee of the County Public Health Commission, as Dr. Kumar pointed out, for monitoring, evaluation, quality assurance, and advocacy. It was this oral health committee that believed that sugar-sweetened beverage policy and action should be initiated in our county, first by the commission and then by the Board of Supervisors. We developed many policy options, such as labeling, restricting sales, increased water access, and a tax on sugar-sweetened beverages. These recommendations went forward to the County Board of Supervisors after getting commission support, but getting the political support necessary from the board was not immediately forthcoming. Next slide. Instead of jumping into the political fray, the county commissioned a study on the obesity epidemic. The study revealed the common theme of sugar-sweetened beverage consumption as a key contributor to obesity, diabetes, and dental caries. This led to developing a credible needs statement that could be packaged and adapted for many audiences, and it became the basis upon which the Oral Health Committee and the Public Health Commission was able to solicit support from the lay and the professional community, including the elected officials. Next slide. Big Soda had already demonstrated very deep pockets, spending millions in California to defeat these measures, including calling the soda tax a grocery tax. But our mantra was, they may have money, but we have the community on the ground. Nursing, educators, child advocates, physicians, the clergy, health centers, the Heart Association, and more. I sat down with our Dental Society president and another board member, and we agreed we would commit to activating our membership. Then key members of the Oral Health Committee, a physician, a nutritionist, and I set about garnering the support throughout Oakland and met with every member of the city council. The next slide. The vice mayor and the mayor were key proponents, and here they are pictured at the campaign headquarters. They picked up the gauntlet to move the tax initiative forward, but the process still had a long way to go. Next slide. First was getting the city council support to put the sugar-sweetened beverage tax on the ballot. This picture here is one of an elated crowd just moments after the Oakland City Council agreed by an 8-0 vote to place the soda tax on the ballot. Next slide. The key campaign messages were developed based on scientific evidence showing the increased risk of diabetes, obesity, and tooth decay, and clear messaging about the use of the tax revenue to raise public awareness through education, to reduce consumption, and interventions to prevent or mitigate the effects of sugar-sweetened beverage consumption. Fortunately, the California Dental Association already had policy on the books in support of measures that would reduce the increased risk of oral diseases like tobacco and soda. So gaining their support was relatively straightforward. Next. With the endorsement of the Dental Society Board, I was able to educate and execute steps to engage the Dental Society membership, forming an ad hoc campaign committee. Educational updates were provided to general membership meetings. We had the vice mayor make a presentation. There were invitations to endorse the ballot measure, to post educational materials in the office and campaign literature outside the office, telephone banking, and financial contributions. Building partnerships at the California Dental Association level was my next objective, including technical assistance and hopefully funding. Next. With individual contributions from my component dental society of nearly $10,000 and in-kind support from the local medical association and others, I was able to brief CDA staff on the campaign and invited key staff members to meet with the campaign steering committee, including the vice mayor and several council members. This led to CDA offering technical support on a pre-election poll and $60,000 to fund it in both San Francisco and Oakland. The positive poll results for Oakland and San Francisco yielded the leverage for a request to the Bloomberg Foundation, yielding several $1 million in advertising to counter Big Soda. Next. When the votes were tabulated in November of 2016, the measure passed by more than 60% in Oakland and in San Francisco, yielding $11 million annually from a 1 cent per ounce soda tax in each of the two cities. This led to the funding of an expanded WIC oral health program, $250,000 for dentists being able to do diabetes screening and triage at 3 federally qualified health centers, hydration stations in every Oakland Unified School to mitigate a concern about lead, as well as make more potable, safe water available, and increase funding for healthy meal programs in schools and recreation centers, and in San Francisco, a $1 million school district-wide dental sealant program. Next. The next story goes back about 10 years. It's an all too common tale of chronic barriers in access to care for nearly 1/3 of California's population. That's right, approximately 10 million Californians were considered experiencing barriers in access to care. Next slide. Over just a few short years, California witnessed a series of blows, making its dental public health resources go from bad to worse. There was a budget crisis that eliminated the adult dental Medicaid program. There was elimination of a very small, but the only statewide school-based prevention program, and the Office of Dental Health at the state level for the largest state in the country was staffed by one staff member. Even successful demonstration programs had little hope of continued funding or being brought to scale. As a dental director for Alameda County and responsible for the success of the EPSDT requirement of assuring referral to dental care for children and youth 0 to 20, I became even more aware of the insurmountable barriers families faced seeking dental care, including in particular the failure of California's Medicaid dental program in attracting sufficient dentists to make those dental services available. Next. I turned to my colleagues at the Alameda County Dental Society, where together we drafted a resolution describing the problem of access and the profound need for policy action at the state level, and calling for a study on the multifaceted problem of access to care impacting nearly a third of all Californians. We gathered input from local member leaders, got feedback from CDA staff, and took the resolution to the regional and statewide all-component caucus, where it was hands down the most provocative resolution discussed. When we took it to the House of Delegates, the resolution on access to care was moved to the top of the two-day agenda and resoundingly adopted by nearly 200 of the association delegates. Over 2 years, 2 work groups, one on workforce and one on access, rigorously worked to develop a report. And that report and its recommendations was finally presented to the House of Delegates. It was a 3-phase, 7-year plan to overcome barriers in access to care and it was adopted. Next slide. What were the key recommendations? The first was hire a dental director with dental public health experience, and you've now seen him in the flesh. We're very pleased to have Dr. Kumar. To develop an oral health plan building on what exists, to work with existing stakeholders and programs, and seek federal and private funding, develop new childhood prevention programs, and all of that today is a reality, and we're now looking towards sustainability. So what are the key takeaways? Next slide. First of all is developing a clear need statement. There's been long-term engagement with the Alameda County Dental Society and CDA, and that need statement had to be clarified. Discovering shared goals and objectives, long-term trusted engagement, respecting each other's process, and building and sustaining the committed partnership. Next slide. In sum, in both stories, the key factors are like the three-legged stool, which requires all three legs to stand. First is developing a clear need that is well-researched and credible. Second is reaching out to stakeholders and people who share a common vision and goals. And finally is forging respectful and committed partnerships that maximize the resources that each bring to the partnership. The result is a critical mass of infrastructure and sustainability. And in today's world, with what we are experiencing in public health and this pandemic, these needs could not be any more important. So these are just a couple of my stories. Each of us is the author of our own story. I encourage you to build a story of infrastructure and sustainability. Thank you.
Thank you so much, Dr. Fine. Really appreciate your presentation and everybody else. So now it's time for our Q&A. So we're gonna invite all of our panelists to join me right over here. And so we're gonna have a virtual Q&A here. So first we're gonna start with some of the questions that showed in our Q&A and chat box. I'm going to start with Dr. Tim Ricks. I know you did a great job answering some of those questions, but can you talk a little bit more about, there's a lot of questions around, you know, lack of guidance when we're working with the patients who are asymptomatic, and just pointing out that a lot of guidance right now are saying about if you have symptomatic, what you do, and we know that many patients are actually carriers and not symptomatic, and where to go with that when it comes to dental treatments and guidance. Would you want to expand on it a little more?
Sure, Bahar. And it's the million-dollar question we're all asking right now. We need to wear N95 mask in treating patients, asymptomatic patients, knowing that they're potentially contagious, even if they're asymptomatic. And the answer is we, you know, from the federal sector, we're still in this period where we are trying to conserve our PPE, especially our N95 mask for hospital settings. And so just as you saw the CDC guidance change with the, you know, with the general public wearing masks, I think once we have a surplus of N95 masks, we may see the guidance change, but at this time, you know, the N95 mask, they're one of the critical things, and we need our medical colleagues that are treating these patients in the hospital to have those masks. And so that, you know, I'd say, you know, the correct answer is follow the CDC guidance, and the CDC guidance right now does not indicate N95 masks for dental professionals.
Mm-hmm. Well, thank you so much. And I know guidelines are changing day by day, so we will follow those. There were a couple of other questions, Dr. Ricks, around basically the integration and teledentistry and how some states are actually lagging the response and adopting those recommendations. Do you want to expand on that as well?
Certainly. So CMS, the Centers for Medicare and Medicaid Services, has given states a template to change any kind of reimbursement plans that they are planning. And basically, if a state, each state has to enact their own reimbursement schedule. So if they're not doing anything different other than you know, in enacting the teledentistry codes, the 2 codes I mentioned before, then there's not much that they have to do. If they're going to reimburse at different rates, however, they have to amend their plan and send it to CMS. So, you know, there's nothing, I don't think, anymore that can be done at the federal level to help states in the process. I think sufficient guidance has been given, but it is the state choice on which codes to reimburse. And you know, I mentioned in the Q&A box that there are also different requirements by the different third-party payers other than Medicaid as well. And there's a link to some ADA guidance in the answer that I provided. And if you go to that, I believe there are 3 or 4 pages worth of specific codes and requirements by different insurers for reimbursement as well.
Great, thank you so much. I'll get back to you with a couple of other questions in a second. And in the meanwhile, for Dr. Kumar and Dr. Fine, there were questions around how to approach the media, how to engage the media, and also how to engage the hospitals when we are working on the and engaging with the partners.
Well, it's interesting, you know, those 2 topics are not part of this webinar series. Otherwise, I would have said, wait for the next webinar to hear the answer. So my thought about engaging the media is there are 2 reasons why journalists get interested in oral health. One is when you have some new data, new report. The other one, when you have a very good story to tell. So one way to engage the media is either have a report, data, or a story that you can engage the media. The other one is what I like to do is do you know, research in our own department to see how other programs have been able to get publicity around their issues, whether it is tobacco, cancer, or some of the MCH programs. So in your local health departments, you can talk to some of your colleagues. The third one is, you know, media always like controversies. So you want to make sure you engage your press office or the public affairs office before you reach out to the journalists about it. So, and then when you reach out, you know, you should know exactly what is that you want to share and why you want to share. And so I have some thoughts about, in California at least, how to do this. And we will have all the schools collecting data on caries and untreated caries. This is school level data as part of the kindergarten oral health assessment. So a nice report during Children's Dental Health Month can generate a lot of interest among the media about oral health and, you know, what steps one should take to prevent cavities. So there are, I see a lot of opportunities around that.
Yes, and I see, yeah, you're welcome. And I see there's a lot of questions around that. So maybe we can discuss how we can expand on some of these details. But for the, given that we don't have much time, so I encourage panelists to keep your answers shorter. So now one question that is coming up is that, what are the plans to resist cutbacks in dental public health in the post-pandemic environment? I don't know which one of you wants to address these questions, but you know, given the environment with COVID-19 and what's happening, how can we think creatively about our field?
I mean, we have two panelists here, Dr. Fine and Dr. Larry Hill, who have a lot of experience at the local level. Do you want to talk about your experience?
We can hear you now, Dr. Hill. Please start again. Please.
A couple of things I think briefly, at least, is that you know, we need to think a little bit broader than what we sometimes do. For example, the whole thing with pneumonia and the folks in nursing homes. And one of the things that some of these folks are succumbing to is pneumonia. And we know that the oral bacteria, if these folks aren't being maintained, if their oral health isn't being maintained, it can contribute to pneumonia. You know, another thing is all the, you know, we need to, I think, start thinking about the stories that are out there about the people who can't get care, the patients with dental emergencies who can't get care, and who are probably, I suspect, still going to emergency rooms, because for many folks, it's still the only place for them to go. And so when somebody's in pain and they don't have insurance and they don't have a dentist, COVID-19 doesn't change that. And so they're still probably going to wind up in the emergency. I think in the emergency rooms, I think we need to think about teaming up with other folks, as was mentioned before, partnerships with folks like emergency room physicians who hate seeing dental emergencies. So I, you know, again, we don't have enough time to really discuss that. I won't go on anymore, but we have to start thinking a little bit outside the box and thinking. We always talk about how oral health relates to so many other general health conditions. I think we really have to start thinking about that more and utilizing those arguments, but being able to demonstrate it with data.
Great.
Yeah, I'd like to add one thing, Bahar, and that is, speaking of thinking outside the box, not unlike with other infectious diseases, dental offices provide, without a doubt, a great opportunity for screening. And it may be going into the future that the dental office is integrated into the overall system of determining the level of infection in the community, not only in terms of protecting from spread amongst those who are treating patients, but also as far as gaining understanding of the extent of infection altogether.
Great, thank you so much. I know we are 3 minutes to 1 o'clock, and I was wondering if we can expand. I know some of you have to leave, but if you can expand our time till 10 after 1 to answer some of the questions. Are our panelists okay with that?
Yes.
Okay, great, fantastic. And for the participants, it's going to be recorded, so any of you that can stay, that's great. Otherwise, the recording will be there. Thank you for that. And Tim, going back to some of the questions that came towards you around fluoridation, and if they're being addressed in the new Surgeon General report, and just what's the take on that with just the new fluoridation environment and all of that.
Well, so that's fluoridation will be prominently in our second Surgeon General's report on oral health. And, you know, in addition, fluoridation continues to be one of our Healthy People objectives. The Healthy People 2030 launch was supposed to happen at the end of March, and it was postponed. But I can tell you, as a member of the oral health work group, that we had to trim the number of objectives from 33 down to 11, but one of those 11 continues to be community water fluoridation. So we still think it is one of the best public health measures there is, and we stand by that. Now, with regard to what's going on with the National Toxicology Program, and just to sort of refresh everyone's memory, the National Toxicology Program had developed a monograph that said in its first sentence that fluoride is presumed to be neurotoxic or a cognitive neurodevelopmental hazard to humans. The National Academies of Science, Engineering, and Medicine, NASEM, released a report a month ago yesterday, in which they identified several issues associated with the protocol that the National Toxicology Program used during their monograph. And so that report was published, the NASEM report. And so we believe that the National Toxicology Program will go back and conduct a new systematic review, and we'll see where that leads us. But I think that answers the question. Fluoridation is certainly going to be part of the report. Thank you.
Great. Thank you so much. Thank you. So there's another question. I'm switching gears to Dr. Kumar. You mentioned that lack of trust in dental providers is a problem for many communities. Are you considering a mid-level position such as dental therapy that would allow more community members to become providers? This would address the issue of trust as other social determinants of these communities, such as broader employment opportunities.
Mm-hmm. California already has one. California has a very liberal dental practice act. Dental hygienists can get advanced training and become independent practitioners in California, participate in the Medicaid program, bill, they can be part of the virtual dental home team. But the issue is, how can we make those practices sustainable? That's a big issue, especially now under COVID. It's going to be extremely difficult for dental practitioners to make a practice sustainable. So we'll have to wait and see. Generally, when you look at dental practices, not only dental practice, in general surgical practices. So there is more money in these procedures that are complicated compared to some of these routine procedures. So if a practitioner is doing, fillings every day, I don't think such a practice will be sustainable in the future. So it has to be, especially with this COVID environment, if dentists have to take all these not only standard precautions, but also transmission-based precautions, it will be very difficult. So maybe the approach should be minimally invasive dentistry and prevention. So that those things become even more important.
Become more important. Great. Thank you so much, Dr. Kumar. So Dr. Hill.
Just a comment on that. I think the question of dental therapists is going to vary state by state, and it has. Dr. Kumar mentioned something about the sustainability, and I think the thing about dental therapists is that they are a lower cost provider for their limited scope of services that they can provide. And the other issue is that they can be a dental extender and go into areas where dentists aren't going. So I think we have to recognize that. And is that going to be a possibility? Well, that's going to be a state by state decision. But it's happening right now. I think they're practicing right now. They're either practicing or legislation's been passed in 12 states at this point. So I think that's something that we'll want to keep a close eye on. But again, that's not the only workforce answer. There's also community dental health coordinators. There's the California Dental Hygiene Program that extends the use of dental hygienists. Teledentistry can be involved in all those models. So I think workforce is going to be a very interesting area for us to keep an eye on.
Definitely, yes.
Thanks.
Thank you so much. And I just wanted to bring attention to our upcoming webinars that we're going to talk about the role of dental hygienists in California a little more in depth when we talk about the sustainability, I think in not this coming one on April 15th, but 2 weeks after, April 27th, I guess. But yeah, it's in our schedule. Thank you so much. So a question for Dr. Fine. Your successes are truly inspirational. Do you have any thoughts as to where to go from here? Big Soda has stopped any further local tax on sugar sweetened drinks. How can we support further action at the local level?
Well, the model of joining together to attempt to enact a ballot measure has run into some legal issues in California, but I think that that's going to be challenged at the state level. I believe that that is still a viable opportunity at the community level, at the city level, to proceed to go about doing that. And it really follows along the lines of what I described and underscores something in this post-pandemic era that I think speaks to the issue of upstream intervention. I think that the dental profession, the dental public health community, and all of our partners are now called upon to find upstream approaches to reducing the morbidity of dental disease altogether before it's necessary to enter into the very expensive realm of getting dental treatment where there is actually a challenge and it's actually more costly. So I think there is great opportunity, and I think it's well worth pursuing.
Great. Thank you so much. Thank you. One more question about funding. And is it possible for oral health specific funding from the federal government to sustain the existing oral health programs? I'm imagining that people are talking about that in the light of the COVID-19. I know we're going to talk in one of our upcoming webinars around some of the federal matching mechanisms, but any other other than the federal matching mechanism, any other information, Tim, that you have around that?
No, I don't. I'm sorry, but I can look into that.
Thank you. Thank you. And yes, we're going to talk about the federal matching money in our sustainability webinar in about a month. Great. Dr. Ricks, thank you for your work. Will the new Surgeon General report address the oral health disparities for individuals with special needs, special healthcare needs?
It will. I'm unmuted, right? Yeah.
Yes, I can hear you.
Yes, it will. We'll have a section on special needs populations, and we certainly are looking at oral health disparities and inequities.
Got it. Great. Yeah, there was a clarity that people were asking about the federal support in the light of the new Surgeon General, if Fed is supporting kind of local activities when it comes to oral health.
Not sure I understand the question. Is the Surgeon General supporting oral health? Is that the question? As
far as the funding, I think that was the question. They were clarifying the funding questions, federal funding.
I mean, like the Action for Dental Health Act provided additional funding to HRSA and Centers for Disease Control. So there has been increases in funding. NIDCR has had an increase as well. So yeah, there's been increases in funding to support oral health and oral health research.
Great, thank you so much.
And like I said, I mean, this is the second Surgeon General to commission a report. So oral health, you know, the quick story, I know we're running out of time, but Surgeon General Adams is an anesthesiologist, and he saw young children being taken to the emergency room, our operating room for complex rehabilitation, and that's what really drove him to prioritize oral health. So he values oral health, and I think it trickles down to all of us.
Thank you so much. Yeah, I'm hearing, I'm seeing some interesting funding questions, and I can sense that, you know, with all changes and all of that, people are a little anxious about funding and how it's going to go. So there's a question about any updates on funding for fiscal year 21, 20 rollover or upcoming changes. I'm not sure if this is for Dr. Kumar or Dr. Ricks, but any updates on any funding, Dr.?
Yeah, you know, everything is up in the air. Our budget was on track, and now everything, you know, has been canceled. All the budget hearings have been canceled. So we are in a waiting mode to hear more about the budget in California. So I'm sure the issues are same at the federal level. They're so occupied now with phase 3 funding, some kind of, you know, CARE Act to support, because it looks like this shelter in place policy will be extended for another, you know, 15 to 30 days. So in that case, people need some kind of support. So that will be, in my opinion, a top priority.
Dr. Hill, yes.
I was just going to mention that, you know, the state and the feds are certainly one place to look for funding. But I think there's some work that has to be done, a different kind of work that has to be done on the local level to find funding. It's not just going to trickle down real easily and quickly from the state and feds right now. They're going to be competing priorities out there like crazy. But I think one of the things to think about is two things. One is as grants are made available, as requests for proposals come out, many of them aren't going to specifically mention dental. And that's where it's really important to create these relationships with other, you know, other health organizations, other social organizations in your community, so that you know what's happening, you know what's coming out, and you partner with these folks to tag on to some grant applications. And the other thing is going to be local, you know, local grants. It's not just the feds in the states, but it's corporate funding, private foundation funding. You know, a lot of times I think we at the local level are hesitant to put a dental grant out there to these folks. And I can tell you that my experience has been that, you know, if you have the guts to do that, and you have an application and a concept that's ready to go and makes sense, that when it's going to come across the desk of some of these folks, they're going to look at that and they're going to go, huh, hadn't thought about dental. That's an interesting concept. Maybe we should look at this. And in fact, the fact that you are dental going into these can be a real benefit, because you're going to be different than everybody else. And a lot of these folks know and understand what the dental issues are, but won't expect to see a dental proposal submitted. And so again, you can't rely on other people to call you or to send you you know, a note and say, hey, we're going to have money available. You know, you gotta go dig for this stuff and look for it. That's it.
Thank you so much. And these are very in line with Dr. Kumar's presentation around sustainability as well, and around advocacy, what Dr. Fine was saying. So they're all kind of, especially in these times with the new challenges, I think it's time to really practice all of those and look at this with those fresh eyes. Well, I wanted to thank you all. Thank you so much for amazing presentations. Thank you all for your patience. Thank you for attendees to working with us. I know there were some quick glitches around having the presentations going right on time. So, you know, we have put this together and we have trained ourselves on doing webinars just recently. So we really appreciate your patience and going with that. So please check our schedule for the next webinars. The next one is on April 15th, Wednesday, April 15th from 9 to 11 a.m. And that's on care coordination, community engagement, and partnership development. So we look forward to seeing you all there. And again, thank you, the panelists. We really appreciate your engagement throughout this time and your flexibility. And best of luck to everybody. Stay safe. Put out some prayers for Myron. Myron has been a big brain behind all of this planning that we have done. And may everybody stay safe and healthy. And we look forward to seeing you all very soon. And thank you so much. Bye.